right, a good segue from Dr. Camacho's talk. I will be talking about ED management of postpartum hemorrhage. So an outline of my talk, I'm going to be first starting to talk about management of hemorrhagic shock in general, what postpartum hemorrhage is, the definition, the causes, the specific treatments, and the takeaways for your next shift. So starting off with the case, we have a 35-year-old G6P5, 39 weeks OB, having a precipitous home delivery. EMS found the patient in a pool of blood, and there are her vital signs. You'll notice that she's tachycardic, hypotensive. On exam, she's diaphoretic, in acute distress, and having active vaginal bleeding. To start off with the management, if you're thinking 2 large bore IVs, oxygen if they're hypoxic, then you would be starting off on a good step. It's similar to any hemorrhagic shock patient to making sure you have good access, getting a type-in screen, activating MTP if necessary, getting your consultants on board early. So again, this would be a situation where you would call a code 54, and then also getting coags and fibrinogen with your labs. So postpartum hemorrhage is a serious complication of maternal morbidity and mortality worldwide. It is defined as a cumulative blood loss of over a liter with signs and symptoms of hypovolemia, regardless of the route of delivery. But typically, when it's a vaginal birth, you worry about anything over 500 cc's of blood. And as a reminder, pregnant women have an increased circulating volume of blood, so they can tolerate a bigger blood loss amount compared to anyone else. But 500 is the cutoff for a vaginal birth. There's 2 separate definitions. The primary type is in the first 24 hours after delivery. And the second is anywhere after 24 hours up to 12 weeks postpartum. And that's usually more from either retained products of conception versus infection causing the secondary type. So the causes, there are 4 T's. That's the mnemonic to help you remember. The first T being tone, so uterine atony. Trauma in terms of lacerations related to delivery. Tissue, so retained products. And thrombin, so coagulopathies. Risk factors, I've listed some here. Placental abruption, previa, having postpartum hemorrhage in the past, having a macroscopic fetus. These are all risk factors of postpartum hemorrhage. So the first one being uterine atony. This is the most common type of or cause of postpartum hemorrhage. And the first thing that you should try is physical maneuvers. So you should be examining your patient, feeling their fundus, and feeling if there's adequate tone. It should feel pretty hard. And if there's a lack of tone, then you can first try a fundal massage, which is in the top right. This is an external maneuver where you kind of compress the uterus through the abdomen. The other type is to do a bimanual uterine massage, which is in the bottom, the lower right. And you can see the outer hand compressing on the fundus and the inside hand kind of pushing hard on the uterus. This is also a helpful maneuver for clot removal, which is related to the T for tissues. Because there can be significant clot burden, the uterus cannot adequately clamp down, so the clot removal can actually help with regaining tone as well. One thing to remember, though, is because there is a lack of tone, you should be aggressive about removing clots, but there is also a risk of uterine perforation since the uterus is not has a lack of tone. So be careful about how aggressive you're clearing out the clots. Try to empty the bladder beforehand to minimize damage to nearby structures. And then also, if time and resources allow, try to use IV or IM narcotics since this is a very painful procedure. Another thing that we can use to help with uterine atony is Bockery, which is the balloon that you see in the top right. This is helpful for balloon tamponade of the uterus. In a pinch, people can also consider using Foley catheters to kind of mimic the same effect. This is mostly helpful for cases of atony. It doesn't really help if you have placental retention. So always try to evacuate the uterus before you decide to put a balloon. This helps because it's essentially like a large Foley catheter that you insert into the uterus and you kind of fill the balloon. This helps because it tamponades the vessels, but it also gives the uterus something to stimulate contractions against. And the use of Bakri actually decreases the need for hysterectomies and other invasive procedures. So when using a Bakri, you should guide it in with ultrasound guidance and fill it up until the bleeding kind of stops, typically around 200 to 300 cc's of water, and using ultrasound guidance to make sure that it doesn't exit into the vaginal cavity, because then now we're kind of working against the uterus on clamping down. They say not to fill over 500 cc's, and then once the Bakri is in place, you should pack the vagina with gauze. However, a caveat is that when the postpartum hemorrhage is over 1.5 liters of bleeding, then the hemostatic effects of Bakri or other kind of tamponade worsens. However, it can still be helpful because you're kind of slowing down the bleeding and then giving them more time to get to the OR. So this is another picture of what it looks like, the Bakri balloon. You first place it in, and then you start filling it slowly until you see a hemostatic effect. A Foley catheter can also be used. You would use like several, maybe 2 or 3 in lieu of having a Bakri, and then filling it up similarly and then watching for hemostatic effects.
For something for the actually EY is moving away from using the Bakri because it's a new device that is put the data that instead of like actually a balloon, it works better for the the physiology of the uterus. It's just a suction device. So you put it in there and we just take the uterus and just completely suction and make it smaller, which like makes more sense if your uterus is like soft already. You're putting on a balloon that it's not gonna make it harder.
Yeah.
So I would call them because they have it in here. All the OBGYNs are in service, so they can bring it to the ER. We connect it to suction. They know how to put it in. It's like suction.
Another tool is uterotonics. And this is a plug for the ACOG SMI app, which is the Safe Motherhood Initiative. This app has like a checklist of things you can go through if you are panicking with a bleeding patient and you forget. So oxytocin or Pitocin is the first line. You can give 10 units IM, and then for maintenance, you can start the infusion. The other ones are Hemabate, Cytotec, and then Methergin. If you can remember, for Hemabate, you should avoid in asthma patients, and for Methergin, you should avoid in hypertensive patients. And just we're not going through these in a stepwise fashion. You should be using multiple in addition to your fundal massage and your bimanual. You can also consider TXA, although it's not well studied in this population. If at this point the uterotonics are going, your massage is going, and it's still not helping, then this could be a time to consider MTP. For the other T, for trauma, this is when the genital tracts suffer lacerations from the delivery itself. So after you rule out atony as a reason for the cause of postpartum hemorrhage, you can look for lacerations. Most of these lacerations are going to be complex and they need better visualization in the OR. So one thing that we can do in the ED is pack it. For the final T for thrombin, we can evaluate for coagulopathies, either inherited or acquired, DIC being the most common one that can be triggered by pregnancy and delivery. A reminder that when you're evaluating for fibrinogen and you're looking for a low fibrinogen level, fibrinogen is actually increased in pregnant women, so a normal level might actually be decreased or lowered for them. Placental abruption or amniotic fluid embolism can also trigger DIC, and you're looking for fibrinolysis and dysfibrinogenemia. So when someone is in DIC, you need to consider replacement of clotting factors and fibrinogen in addition to transfusing with packed red blood cells. And this is just for our knowledge to know not exactly what we would do in the ED, but there are options for uterine artery embolization by IR, ligation of the internal iliac arteries, or eventually a hysterectomy if the postpartum hemorrhage is really bad. Also, you can consider a D&C for retained products of conception in like the secondary postpartum hemorrhage case. So as a review, the 4 T's are tone, trauma, tissue, and thrombin. You start with the basic management for any hemorrhagic shock patient, getting good access, getting type and screen, getting your consultants in early and starting resuscitation. For the first T of tone, try your fundal massage, try the bimanual massage, consider the suction like Dr. Camacho was saying, and then also using uterotonics. And that also relates to T for tissue, which is the manual evacuation, assess for clots, quickly and aggressively evacuate the clots, so then you can help with the tone. For trauma, you can pack, and if needed, you can try repair, but this is typically better done in the OR with better visualization. And then for thrombin, consider DIC if you have a person who is persistently bleeding. That's everything.